I'm Casey Hermsdorf, and my case study today is over treating obesity, and we're going to talk about the benefits and downfalls of treating obesity and the use of drugs and surgery. So, first off, let's start with the background of obesity and how it deals with the surgery and drugs. So, over 1/3 of the world's adults are obese. And obesity is a predictor of coronary heart disease, and coronary heart disease is one of the leading causes of death in the world. Some comorbidities that come with obesity are hyperlipidemia, stroke, cardiovascular disease, hypertension, osteoarthritis, type 2 diabetes, high blood pressure. And there are more comorbidities, but those are just the main ones that most of the obese people get. And so some background on bariatric surgery is this surgery causes weight loss by restricting the amount of food the stomach can hold. So that's the main way that these people lose weight, because it is restricting how much food can go into the stomach, so they're not as hungry or they don't eat as much. The most common bariatric surgeries are the gastric bypass, sleeve gastrectomy, adjustable gastric band, and the biliopancreatic diversion with duodenal switch, which is also referred as BPD. Most of the people that qualify for bariatric surgery are people with a BMI of at least 40 or people with a BMI of 35, but also have serious coexisting medical conditions like mentioned earlier or other conditions. So this is one of the first ones that I mentioned. This is the Roux-en-Y gastric bypass. And so in this picture you can see that we have the duodenum, the jejunum, and the surgery over here. This is the gastric pouch that is put into the duodenum, and so it goes all the way into the jejunum. And so when the person eats the food, it's actually going to be bypassed to this tube and not actually go directly in there. So they're not going to eat as much. They're going to get full faster, which leads to weight loss in the end for these obese patients. So right here is the bypass portion of the stomach. And the arrows are showing where food's going and then the digestive juices that come along with getting this. The next is the sleeve gastrectomy. So this is the normal picture right here before the surgery of the digestive system, and then this is after the surgery. And so right here you can see this is where it's placed, and so that part is where the food doesn't enter. It actually enters that sleeve, so there's not as much room for food again, therefore leading to the weight loss. And then the adjustable gastric band is another one, and this is where the stomach opening can be tightened or loosened over time to change the size of passage. So they put in a pouch right here, and so it can be tightened or loosened, leading to taking in less nutrients, taking in less food, or it can also be expanded so where they can take in a little bit more. So once again, causes weight loss. The last one, the BPD, this is where the first step, the stomach is divided and a large portion of the stomach is removed. The sleeve gastrectomy is performed, so it does incorporate the sleeve gastrectomy, and then the pylorus remains intact rather than being bypassed. So that's shown where this number 1 step is right here. So they keep the pylorus intact. And so secondly, in this surgery, the small intestine is divided at the duodenum and is rerouted so that the ileum, which is the bottom third of the small intestine, now connects to the pylorus, bypassing the jejunum. So that can be seen right here. And then thirdly, the food is rerouted into the digestive loop, as you can see at this bottom portion. So it bypasses the jejunum and the small intestine. And then the biliopancreatic loop, which is the name of this surgery, joins the digestive loop performing a common channel which flows into the colon, which is this common channel right here. And this procedure produces the amount of calories and nutrients that can be absorbed, resulting in the weight loss. So we've talked about the surgery, so now let's go into the drugs for the treatment for obesity. So the three main drugs that are used is orlistat, lorcaserin, and then there's also a combination of phentermine and extended release topiramate. So first, the orlistat, it's usually recommended for the adolescents and the adults only, and it prevents the absorption of fats from the human diet by acting as a lipase inhibitor, which therefore reduces the caloric intake. And then the commonly known Belvic, this is for adults only. It's not recommended for the adolescents. It has a serogenic properties and acts as an anuretic, so which is an appetite suppressant, making you less hungry, more full when you eat just a little bit. And then the combination drug one is for adults only again, and it is an appetite suppressant similar to amphetamine, and then the topiramate is a seizure medication, so it's also an anticonvulsant. So let's talk about the benefits first, and in regards to surgery, there are economic benefits. So in general, 2.8% of healthcare in the world is used on obese people. So those people who are obese tend to have those comorbidities like talked about earlier, type 2 diabetes, mellitus, high blood pressure, etc. And these all account for trips to the hospital and or the doctor, which all cost money. So you can imagine how much that is in the entire lifetime. So an average doctor appointment costs about $72, and then the average hospital visit, depending on what you're going to the hospital for, will cost around $300. So the amount per year that an obese person spends on medical conditions is about $2,300 per year for an obese person. And so, $14,000 to $20,000. And so a study that I found, this averages that before surgery, the annual hospital costs were $2,300, and then after surgery for 12 months, it was reduced to $1,417, and then after 24 months, it was around $560. So you can see that there is an economic benefit in that when you get the surgery, even though the surgery does cost around $14,000 to $20,000, it will add up over the lifetime and being less than the average medical costs and hospitalizations. And another benefit is that it is proven to have weight loss in over half the patients that get these surgeries. And so a benefit of using drugs, there's a study about the drugs of Cameron and Vasprin combination drug therapy. And what this did was it targeted adipose tissue, which is the main tissue used in obesity. And then Vasprin targets adipose tissue as well. And so they act as regulators of metabolism and food consumption. So these two together are able to interact with the cell migration, the glucose uptake, and lipolysis and food intake to alter the increase of adipose tissue and appetite. So it's going to help you lose weight over time, targeting this adipose tissue, helping it to decrease, and helping your metabolism and your appetite to not be as big as it is in obese patients. So as we have benefits, there are also downfalls of drugs for obesity and surgery. So the bariatric surgery can actually result in an increase in binge eating disorder. 30% of people who get this surgery are likely to have binge eating disorder after the surgery. And there's also an increase in alcohol use disorders. And so if the current alcohol use disorder, the person has this for the surgery, they are more likely to relapse after the surgery because this surgery alters alcohol consumptions because it's easier to become intoxicated with alcohol even with no history of alcohol abuse. So there are also post-surgery complications. There's nutrient malabsorption, dehydration, and electrolyte imbalances. These are all potential threats after the surgery. And so for the drug side effects, there's paresthesia, nasopharyngitis, insomnia, constipation, sleep disorder, mood disorder, and exerostomia. And so some other side effects with these drugs have been shown that people get urinary tract infections, blurred vision, nausea, influenza, dizziness, anxiety, depression, fatigue, increased serum creatinine, and dysgeusia. And so, to conclude all of this information, there are benefits and downfalls of both drug and surgery use for obesity. So, the conclusion would be that recommend diet and exercise first for these obese patients, whether they want to take the risk or not, because there are downfalls that are very serious. So if this diet and exercise recommendation doesn't work, then if one can meet the qualifications to get the surgery, then that would be okay, but make sure to make them aware of these side effects and downfalls. So it's up to the integrity of the patient to decide whether the surgery or drug therapy is useful for them. Thank you.